So we are going to learn about TMJ and muscle palpation for the patients. क्या exact क्या problem हो रहा है?
Clicking. Then there is sometimes that I have like I bite on my tongue. So that happens when I'm waking up in the morning. I feel like my tongue is sore. Only on one side and TMJ बहुत क्लिक हो रहा है.
Click हो रहा है.
रिसेंटली बहुत ज़्यादा हो गया फ्रीक्वेंसी. पहले एकदम बड़ा ओपन करने पे कभी कभार क्लिकिंग होता था. नाउ नॉर्मल लाइक व्हेन आई एम टॉकिंग आल्सो समटाइम्स इट क्लिक्स.
That means that chronically there was some problem which is getting acute day by day. Either it is because of increased stress leading to more bruxism or change of mattress or pillow.
No.
Change in schedule, sleep cycle.
No, I'm sleeping well. मतलब 6-7 hours आराम से हो जाता है. Stress maybe, but I don't know. मतलब I feel I have a deep bite. Then one side posterior crossbite भी है slightly. So I have always wanted to go for ortho, but हमेशा कुछ ना कुछ ये था कि पेरेंट्स वाला कि नहीं फेस स्ट्रक्चर चेंज हो गया तो कुछ हो जाएगा क्या ये वो है देन बट आई उसके बाद तब क्लिकिंग नहीं था. इवेंचुअली नाउ द क्लिकिंग हैज स्टार्टेड.
Now the clicking has started. ठीक है तो palpate करते हैं.
जब से मुझे समझ में आने लगा कि क्या होता है, बट अभी रिसेंटली इन पास्ट 1.5-2 years तो बहुत हो गया. और अभी तो बहुत ही लाइक व्हेन टॉकिंग आल्सो इट इज हैपनिंग. अभी
इट इज हैपनिंग. अच्छा अभी भी क्लिक हो रहा है मतलब प्रीवियसली द रेंज ऑफ मोशन जिस पे क्लिक होता था वाज लार्जर. नाउ द रेंज ऑफ मोशन हैज स्टार्टेड रिड्यूसिंग. ओके मतलब यू आर गोइंग टूवर्ड्स मोर ऑफ इंटरनल डिरेंजमेंट ऑफ द जॉइंट. धीरे धीरे वहाँ तक आ रहा है. ठीक है विल सी. अभी फर्स्ट व्हाट वी चेक इज द फेशियल एसिमेट्री. तो फेशियल एसिमेट्री में कुछ मेजर नहीं है. मे बी अ स्लाइट स्वेलिंग ओवर हेयर दिस साइड. विच साइड you prefer for eating? You're eating from both sides. Okay, so what I can see from the front is this side is slightly more elevated here than this side. This looks more flatter. This masseter looks slightly elevated. Okay, rest is okay. Then we start checking for the muscles and then we will do it for the joint. So muscles mein first what we check is open. We check the masseter. Okay, open. Now we try to find where the maximum pain trigger point is. So this is the pain trigger point. Maximum here is the pain. Okay, now this pressure and this pressure is the same, right? Now here what I am applying, you are not having any pain. Open. Here what I am applying is the same pressure, है ना? Grade this pain from 1 to 10.
Around 7.
7. Okay, we'll do it on the other side. Open. Now here I think the same area.
Less.
Open. This area you're feeling. So this is one of the trigger point of the masseter. ठीक है. So this is the way we find out the trigger point. Massage that area slightly and we find out. Okay, this is also 7, almost 7. Same. Okay, now open. Close. Now there is a very slight amount of deviation on the right side. Open. पहले right side में आ रहा है. So what the movement is happening, it's going on the right side then coming into the center. If it was going to the right side and not coming back to the center, it's known as deflection. If it is going to the right side coming back to the center, it is deviation. Okay? Okay. Now we will check the temporalis. So temporalis is here. So okay. So temporalis is this masseter. Actually the fibers are vertical. So how we have to palpate is horizontal, front and back. We palpate perpendicular to the muscle always. We never palpate parallel to the muscle. So if I palpate this way, we won't be able to feel anything. We have to palpate for trigger point. What is trigger point? The area where the belly of the muscle is most knotted. So there is a muscle fibrosis has occurred because of overuse or because of misuse. So that is a trigger point which we palpate. Then the temporalis is a fan shaped muscle. It is like this. So here also we will palpate like this. So temporalis, no, we have to start palpating from the temple area, but we go behind also because it's a bigger. And when we wear the spectacles. So where that dundee of the spectacles lie, that is the area also of the temporalis. So that also we palpate. Not only the temple area, we palpate. So here I can see some fibers. You can feel some pain.
Yes.
Okay, and here also we'll see similar area we'll find. This is the main belly because इतना नहीं, यहाँ पे ज़्यादा हो रहा है. Deviation is also on the right side. So what it means that the right side muscles are slightly more tighter and active than the left side. Here also we are having some, what I can feel. This is the main belly because from here in the coronary notch, it goes up, है ना? And it attaches to the side of the skull. And here some accessory fibers are attached. ठीक. This is the temporalis. Now we do for the middle pterygoid. So middle pterygoid will do inside. Okay, and okay. First, let the patient get comfortable with the actual normal digital pressure, the pressure of the fingers. Now you open your mouth and slightly do left, right, more. Here also I am feeling a lot of click. Yeah. Here you are feeling any pain? Yeah. So the middle pterygoid is also in spasm. Okay. Here this side. Little less, but कुछ डेंटल ट्रीटमेंट नहीं हुआ था ना, INB ब्लॉक वगैरह कुछ? कब हुआ था?
बहुत पहले, मतलब for my 2 premolars lower, so they were when they erupted only they were मतलब brown ही erupt हुए थे. I think there was some anomaly. मैं बहुत छोटी थी, तो the doctor has done the treatment and he said कि crown मत दो, इसको eventually ortho करेंगे, वो निकाल ही देंगे. So एक में उसने क्राउन नहीं दिया और एक में क्राउन दिया है. And I feel उसके बाद शायद because वो full occlusion में भी नहीं आया कभी दांत, मतलब they were
अच्छा नहीं आया उसमें. Okay, ठीक है. So here we can feel some this border ना, this is the border which is painful. So middle pterygoid is very painful over here. This border, this is not that much painful ना. यहाँ पे नहीं है. ठीक है. So we got some idea from the palpation that what may be causing the pain. Now we palpate. Now we do the load testing for the lateral pterygoid. So this is a cup method. Open your mouth. Open. Any pain in the ears? Near the ears? ठीक है. Move it forward. Where? So यहाँ पे click भी हुआ ना. So this side lateral pterygoid is heavily spasmodic. So this was a very classical sign. ठीक है. Now I am going to do joint load testing. So joint load testing, how we do? This is known as Rocca-Bado's joint load testing. This is a classical sign of internal derangement of the joint. Okay. So what we'll do is open your mouth, leave it absolutely loose. Okay. Absolutely loose. Let it loose. हाँ, पीछे रेस्ट कर लो. लूज एकदम. हाँ. Any pain here? एकदम लूज रखो. हाँ. Yeah. No pain, ना? So what I am doing basically, I am placing my thumb on the teeth. I am supporting the mandible from the bottom at the corner, and very loose. Yeah. Very loose. Still not loose. Very loose. Yeah. What I am doing is I am putting. Yeah. So her Rocca-Bado test is positive on the right side. So what I am doing is actually I am just occlusals. I am pressing my thumb and I am guiding the mandible superiorly and posteriorly. So what I am doing by supporting, I am supporting it so that it is free, and then I am pressing from the bottom. You did not feel pain here, no? You felt pain here. So this is a very classical sign of positive internal derangement of the TMJ. So this patient is a TMJ patient, primarily a TM joint patient, not only a muscle patient. Muscle तो होगा ही, TM joint तक आया है तो पहले muscle तक होके आएगा ना, but definitely TM joint involved है इसमें, only muscle नहीं है. Okay. Now we check now after all this we do the palpation of the TMJ. समझ गए? हाँ. So open, close. Okay. Now a huge click on the right side and even on the left side. Now we do open and closing, and then we do right and left. Both right and left दोनों साइड पे we are getting click, and open and close में भी we are getting click. ज़्यादा मत करो. अच्छा खासा deviation हो रहा है. So this is definitely a TM joint. Now it may be occurred because of interferences in the teeth. It may not have occurred because of interferences on the teeth. That is not the question. The question is what we will do for the patient now. So my line of treatment is, first we give laser on the TMJ in the right side to relieve her of the acute pain, because that is first empathetic thing I can do for the patient. Splint film बनने में 1 हफ्ता लग जाएगा. First we help the patient by giving a TM joint physiotherapy. Then we do a MRI. MRI may we understand how much the disc has deviated anteriorly or medially or laterally. It will show us, and based on that we do the splint. Now in this patient the history is very near, very recent. So maybe by putting a protrusive splint where we are guiding the teeth in the front, mandible we are guiding in the front, and we are making a splint at that position, maybe we will be able to recapture the disc which has got repositioned anteriorly. Okay, now I'll tell you theoretically what is happening in your joint. Your disc has moved. Your disc was supposed to be here when the joint was closed, when the teeth were closed. The disc was supposed to be between the condyle and the glenoid fossa, but for some reason your disc has gone anteriorly in the closed mouth position. Now it actually has to go anteriorly in the translation open mouth position. Actually it has gone anteriorly in the closed mouth position. Now it is here and your joint is here. Now when you are trying to open, what is happening? This anterior part of the condyle, it is hitting the disc ka posterior part, which is a thicker part, which already is in ahead of it. So it is hitting. When it is hitting, it is causing you pain and it is causing the click. And sometimes what happens, when you open, there is a pain. You try to open more, what happens? The distance between the glenoid fossa and the condyle increases. So the disc gets some space to get recaptured. So it recaptures. That is the point when you feel the click, and then you are able to open more. So this is what is happening theoretically. So what we have to do is, with the splint, what will happen? In your closed mouth. Now when I did the load testing, the Rocco-Batto load test, what I did, the disc, there is no disc in the closed mouth position. There is hardly any disc in the open mouth position. When you are at this position, I am forcing the condyle in the glenoid fossa. I am forcing it superiorly. I am putting pressure in the mandible, corner of the mandible, forcing it superior. If there is a good fibrocartilaginous disc which is not does not have any nerve, does not have any blood vessel, it is only a pure disc, then you will not feel any pain because it is a cushion. But what is happening? Because the disc is in front, the retrodiscal tissue, which is highly innervated, actually has come forward, and when I am pressing your condyle to the glenoid fossa superiorly, what actually is happening is the condyle is digging into the retrodiscal tissue. That is why you are feeling pain. Actually, you should not feel pain when we are putting pressure vertically upwards, because if there is a disc involved, you will not feel pain. But this is why you are feeling pain. This is how I know that her disc is anterior to the condyle. So kitna anterior hai, medial hai, lateral hai, whatever it is, basically it is displaced, and we have an internal disc derangement issue, pure internal disc derangement issue, and that is why there is a deviation. Now what we will do, what the splint will do, we'll do MRI, we'll do all that. What the splint will finally do, it will force your mouth to be open first. So the joint space will increase. So normal joint space is 1.2 mm, it will increase to 1.8 mm, 1.6 mm, slightly it will increase. And what will happen, there will be a high chance that when the muscles are relaxed, the lateral pterygoid, which is pulling the disc ahead, is completely relaxed. The disc may recapture behind and it may go behind. Okay, if with that the symptoms are not disappearing, maybe your retrodiscal tissue will start behaving as the disc. So there is high adaptability because you are a young patient. Or there may be a possibility that we may need to do surgery and reposition the disc behind by doing something known as plication. Open TM joint surgery, we pull the disc behind and we ligate it over there so that it becomes a proper position. But splint 100% has to be bone. Okay.